Recording in progress. Sorry, I'm running a little late, guys. Just barely got in here on time, and I don't have actually the right glasses with me, but that's okay. I have some. So, here we are. Here we are. It is Saturday. It's Valentine's Day. Just really actually occurred to me. So it's great to see you all as you're coming into the Wondrous Roots classroom. Uh, my name is Becky Montrone. We have a business here in Keene, New Hampshire called Wondrous Roots. So am a certified holistic healthcare practitioner with a degree in holistic nutrition, and I'm also a clinical herbalist. So I meet with clients one-on-one for all kinds of health problems to help from my angle of use supplements a lot, very therapeutically speaking. So that's kind of like known as orthomolecular medicine, actually, is a term they have for that. Using nutrients in forms and doses that are more therapeutic than, say, well, I don't have scurvy, or I get a lot of vitamin C from my diet. We might be using high dose vitamin C for for something like cancer or something like that. So anyway, doing that, certainly lifestyle management, anti-aging, very into that with bioidentical hormone, um, recognition of the importance of our hormones, the importance of our mitochondrial energy, the importance of antioxidants in our diet, really, really huge importance of DNA methylation and that foundational aspect to health. So we have a lot better track record, I say, looking at things like this when it comes to chronic disease, when it comes to the chronic illnesses facing our population, such as metabolic disease, cardiac, pulmonary, so COPD, lung health, things like diabetes, cardiac, things that get people over time. And that can really be um, and I would say probably most cases, if paid attention to earlier in life, prevented. And then if they ensue during older years, definitely mitigated, slowed down, in some cases reversed. So that's really exciting. It's very exciting. So anyway, welcome again, February 14th, 2026. And I've been doing a series on, I usually give like how to reach me. So our number here is 603-439-2603. Our business hours, our open shop business hours are 9:30 to 5, Monday through Friday. We have two websites. One is wondrousroots.org, which is dedicated mostly to learning. So I have tons of information on there on different topics. A lot of these videos are found there. You can also find if you're tuning in for the first time or whatever, YouTube channel, my YouTube channel, my Rumble channel. But I usually have material that goes with them. And so I put them into places on my website where they make sense. So if you're looking for information about something, you should be able to find it. Then that's wondrousroots.org. And then we have wondrousroots.com. Shopwondrousroots.com is our online store. So we have tons of products here. I stock a lot of supplements from other vendors as I use them with my clients, and I'm enthusiastic about them, and we sell them here, make them available to the public as well, here locally and online. And then I have a full armamentum of herbal formulas that are my own creations. Included in that would be our skincare line, which is super popular, and a lot of tincture formulations and some other topical things. So anyway, you can check that out, shopwondrousroots.com. All right. I think that does it for my intro. It's so pretty out there. Here in Keene, New Hampshire, we've got a little bit of snow flurry, like not much at all. So as many of you know, my husband Dale ridiculously had a ridiculous complication to norovirus, the simple stomach flu he had back on December 10th. And he has had a time of it ever since. And he's in very serious condition. Long story short, he developed what is called an ileus. So it's like a paralysis between his small and large intestine. And so since the time he had the virus, he was really unable to eat or and became unable to eliminate. And it's been a very painful process. It's been a very laborious process. He's entering this coming week will be his seventh week in the hospital. Um, and he right now is, well, I'm going to explain a little bit more about that when I get down in my presentation to things that can happen to you that are life-changing from an acute illness. And I've got a couple of other examples, and one of them involves sudden hearing loss, which is very recent. So I'll wait and tell you more about that then. But please keep him in your prayers. Dale desperately needs that. Anyway, okay. And the other thing I will say is I have canceled some people's appointments. And you might say, well, how come you can do a webinar, but you can't do my appointment? Well, it all is about what's going on with him, what's going on that particular day at the hospital, what's going on. Right now, he's being kept in a medicated coma, so to speak, if you would. He's very sedated because his abdomen is being left open, waiting for a second surgery. On Monday. So they've gone in and washed his abdomen. It's all open. It's not open to the air. I mean, they have it packed and stuff, but you can't be awake with your abdomen sliced open. So he doesn't know that I'm not there. Let's put it that way. I can't be of any help to him, and I will be going over to sit with him a little later. But anyway, that's where it is. That sounds really scary, doesn't it? Ooh. Anyway, so yes, so sometimes I just have to cancel people's appointments because I cannot tie myself down to a certain time of day, um, depending on what's going on in his course. So please forgive me and understand. All right, now I am going to open my presentation. We're talking about the ears. So this is the five sense series I'm doing, and this is number two, the ears, and this is number two in the ears. So I've got to find it. Give me 1 second. Educational presentation probably is right here. The ears. Yes, part two, PDF. Okay. So I want to kind of bring that down, pull it out just a little bit. That looks about right. Yeah. Okay. And then where are you? There we are. Okay. Share my screen. All right. And then put you, if you want to participate. Whoops. Gosh, I always do this, don't I? Now I moved this bar where I didn't want it. I didn't want to move the whole bar. Whatever. Okay. All right. My chat over here. If you want to say anything, and please do participate, type into the chat. You can type into the Q&A, and you can also talk. So yeah, where are my participants? There you are. Okay. So you can raise your hand and then you can talk. All right. So you should be able to see that. The ears part two, hearing loss under the microscope. And that was another thing. Like when I was planning, and 2 weeks in a row, I've canceled doing this webinar because of what's going on with Dale. I said I was going to do all the problems with the ears, right? Well, there's a lot of problems you can have with the ears. And I thought, as I got going on hearing loss is enough for 1 hour. So then next week we're going to go, or the next time, depending on what's going on with Dale, next time we will do like the other, well, anyway, like tinnitus and other auditory disturbances, and then we'll move into the vestibular processes. So, maintaining balance, Ménière's, all of that kind of thing, vertigo. So bear with me. It's really kind of, you're learning along with me because as I have rudimentary understanding of certain things, when I build these presentations, I learn a lot more, and then I'm very excited and very excited to share with you. So here we go. So here we go. And when I first actually put this together, I didn't change my session focus after I decided to change, but I said real world things that aren't going well, but we're actually going to focus on hearing related issues. And we're going to stick with that for like 69 slides. So buckle up. All right. Um, All right, common patterns of hearing loss, what they reveal about where the problem originates. The final session, like I did with the eyes, for the ears is going to be all about how we keep our ears healthy. And many times it's how we keep our ears healthy is how we keep everything else healthy. And that's really good to know. But I think a lot of times when we're young, especially with hearing, we take our hearing for granted. We don't have hearing problems, and we can be doing things that really damage our ears, as we're about to see, that set us up for problems later on. So, anyway, the types of hearing loss, um, sensorineural, okay, and then conductive. They're different. Um, sensorineural, oh man, this is going to get me. Sensorineural is more of what you see coming with aging. Can be provoked by damage from noise, like people like my father-in-law who taught shop and was always like, they didn't wear ear protection back then. And they, was always with saws and all kinds of stuff like that. Ended up with hearing problems and tinnitus. Um, you can get sensorineural hearing loss from some drug side effects, from auditory tumors, from being like somebody emailed me, no, commented in the first one on YouTube that he had had a problem with tinnitus since he was at a blast explosion when he was like 8 years old, and just something he's had to live with. Uh, so I'm not sure about his hearing loss, but something like that, like a really big explosion. Um, and then conductive hearing loss is more like you've got a foreign object in your ear, you've got impacted earwax, maybe you ruptured your eardrum, you might have fluid in your ears, that kind of thing, something that shouldn't be in there. And those things are usually, you know, you can treat them, you can fix them. So, what is sensory neural hearing loss anyway? Damage to the cochlea or the auditory nerve. We went through, been a couple weeks, but we went through like, and you're going to see it over and over again in this presentation, like pictures of the insides of the ear. So don't worry if you can't like call it right up to your memory right this second. Um, okay, the cochlea, right, is that looks like a snail, and that's where the hearing, the little hairs are, and that's where sound is picked up by the auditory nerve. So if the auditory nerve is either one has problems, you can end up with sensory neural hearing loss. So that's what it kind of means, like the sensory, the sense, and then neural would be involving the nerve. Sensory neural hearing loss is often permanent, which is why people end up with hearing aids. Common causes, aging, noise exposure, viral injury. We're going to be talking about that later on, and that's pretty interesting. Toxins, vascular compromise. So you might have something that interrupts your blood flow the to the ear, to the areas of the ear that are they're all important, but you know what I mean, that are involved with the hearing. And we're going to find out a little bit later on that, well, I'll say it now, but I'll repeat it then. There's like a microvascular blood supply, and there's not like something to take over if it gets interrupted. There's not like a backup system. So anyway, so again, here's the cochlea, the auditory nerve. The auditory nerve, we'll talk about that a little bit later. It's really cranial nerve eight, and it's composed of three different nerves. Here we've got these little cool things, the anvil, the hammer, and the stirrup. And they're locked, the stirrup is locked right in there to the oval window, if you recall that. Over here, this is giving rise to the vestibular apparatus. Maintains our balance and stuff like that. This is all about hearing. I just think it's really cool the way that looks. Okay, so anyway, sensorineural hearing loss occurs when the sound is successfully delivered to the inner ear, but the inner ear or the auditory nerve cannot properly convert or transmit that sound to the brain. In other words, the mechanics may be working, but the sensory or neural components are impaired. This type of hearing loss involves damage to one or both of the cochlea, especially the delicate hair cells, those little cilia, and the auditory cochlear nerve, which carries sound information to the brain. Again, here's a refresher on how hearing normally works. Sound waves enter the ear and are mechanically amplified. Vibrations reach the cochlea. Hair cells bend, they're inside, in response to sound, converting signals into vibration into electrical signals. The auditory nerve, which is missing there, and that is there, but it comes off the cochlea, carries those signals to the brain for interpretation, and that's what you are actually doing when you hear. But you've got to have all parts, right? I mean, it's like you got to have all the parts in place to get that so the brain can do that. In sensorineural loss, step 3 or 4 break down. So the hair cells or the auditory nerve. This part here all happens here. So this is not where the sensorineural hearing problem lies. It's once you get over here. So there we have a good diagram of that. If the outer ear is okay, the middle ear is okay, whoops, this is where we have the problem. How sensorineural hearing loss happens. Hair cell damage is the most common. The cochlea contain thousands of hair cells arranged by frequency. High frequency hair cells are especially fragile. Once damaged, they do not regenerate. This is the problem. It's one thing, like even your brain will regenerate, right? But your hair cells that allow you to hear do not. Now, I did in my kind of wanderings find something where someone was saying, regenerate those cochleal hair cells, blah, blah, blah. But I didn't look into it. I'll do that when I work on the one about what to do and see if there's anything to that. But it sounded like a scam to me. I mean, they can do cochlear implants, but this was actually talking about like regrowing the hairs, which is supposedly you're not supposed to be able to do. So just saying. So common causes, aging, chronic noise exposure, sudden acoustic trauma like that blast, viral infections, including COVID-19, and that's going to be my case study moving on through this program. Person here who had a very interesting and unfortunate like sudden hearing loss that's irreversible due to being having the COVID-19 virus. Ototoxic medications or toxins and reduced blood flow or oxygen delivery. Those are your major problems there. So here you can kind of see these little hair cells. These are what the normal ones look like in your cochlea. The damaged hair cells, oh, they're not looking too good. And this one, they're really damaged. So you can see, you can hear fine here, not so great here, and really not great here. Auditory nerve damage. So the auditory nerve is interesting because you're like, well, what is the auditory nerve? So I had to really look into that, and I got to the bottom of it. Less common, but often more complex. So cases include viral or inflammatory neuritis. So some sort of an inflammation of the nerve itself. Autoimmune inner ear disease. Tumors that can affect the nerve. And long-standing metabolic or vascular compromise. So just like, say, with diabetes, you can have nerve injury because of glycation to the nerves, your peripheral nerves, and also to the small little vascular structures of the retina and of the kidneys. So you can end up having vascular damage to the blood, little microvascular musculature that is involved with the ear. Neurodegenerative processes can really affect, can lap over and affect other things that go on in the brain, such as vision. We talked about that with vision and with hearing as well. So this can result in distorted sound, poor speech clarity, difficulty understanding speech in noisy environments. So I can remember, you kind of see that if you see people who have that. This is the most common form of hearing loss as people get older, right? So they're kind of like, especially if there's a lot going on and you're saying something to somebody, like I'm thinking of my father-in-law, go like that. What? Because other people are talking and stuff, and it really makes it hard for me to focus in on what you're talking about. So let me just try to pull this down a little bit. The auditory nerve is known as cranial nerve number 8. There are 12 cranial nerves. The term auditory nerve is commonly used as an umbrella term, but anatomically it refers to cranial nerve 8, formerly known as the vestibulo-cochlear nerve. This nerve is made up of two distinct branches, the cochlear nerve, oh my gosh, coming from the cochlea, which carries sound information from the cochlea to the brain, and the vestibular nerve, which carries balance and spatial orientation information from the inner ear. Although these functions are different, the two branches travel together, share anatomical space and blood supply, and enter the brain as a single nerve, which is why hearing and balance symptoms so often overlap. Okay, so there you have a little bit of a better. This is moving on to the brain. A lot of stuff going on in our bodies we're not aware of, right? What it feels like to the person. I was just kind of talking about that with my father-in-law as an example. Sensorineural hearing loss is often not about loudness, it's about clarity. Common complaints. I hear people talking, but I can't understand what they're saying. Everyone sounds like they're mumbling. Background noise makes everything worse. High-pitched voices are hardest to hear. Tinnitus is frequently present along with it. And this is why many people are told their hearing is normal, yet struggle daily. Pattern and progression. The typical progression is often gradual, especially with age-related or noise-induced loss. So here's the deal. If you have some hearing loss now, and it's just starting, or you have none, it could well be in your future, just based on aging and life. So that's why it's really going to be important to be proactive, to protect and really treat your ears with TLC while they're working really well for you. Often gradual, especially with age-related or noise-induced loss, commonly starts with high frequencies. And we're going to get into high frequency. We're going to focus in on that shortly. High frequency hearing loss. Speech discrimination worsens over time. So again, that everybody sounds like they're mumbling. And that makes you feel, and I've seen this in people, it makes you feel so embarrassed. You're like, excuse me? Excuse me, could you repeat that? And you get really sick of saying that to people. And so, yeah, it can actually lead to isolation because you don't enjoy being with people because it's uncomfortable. Can be asymmetrical, one ear worse than the other. Sudden sensorineural hearing loss can occur rapidly within hours to days, often inflammatory, viral, or vascular. Considered time sensitive. Outcome depends on the cause, the severity, the speed of intervention. So again, that's what we're going to talk about when we talk about my client case. She developed hearing loss, profound hearing loss in her right ear when she had COVID. All right. Speed of intervention. Is it reversible? Structural noise-induced hearing loss can be permanent and irreversible. Structural damage to the hair cells or nerve tissue is generally permanent. Early or functional components may improve if inflammation, circulation, or metabolic stress is addressed promptly. If it's something like that, if it's metabolic stress, like very high blood sugar, inflammation, circulation. So the inflammation could come from an illness or circulatory problem. But once the hair cells are destroyed, the body does not replace them. What is typically done about it? Conventional approaches are hearing aids to amplify and clarify sound, cochlear implants in severe cases, and then prompt medical attention for sudden losses. Like if you have real inflammation, they might be able to give you some prednisone or something like that and bring that inflammation down rapidly. They don't restore damaged structures, but that would be like in something really acute, not like a gradual. You don't get like a gradual inflammation in your ear. So they're talking about if something weird happens and you have inflammation. These approaches do not restore damaged structures, but they can improve function and quality of life. And thank God that we have them, although I've met very few people. I don't know about you, maybe you yourself, but maybe also somebody you know, because everybody knows people with hearing loss. It's very hard to get the hearing aids right, is what I've heard. That's very frustrating. Conductive hearing loss. Now, this is the other major form of hearing loss, impaired sound transmission through the outer or middle ear. So now we're getting into everything that we did with sensorineural hearing loss was over here, out of the picture, was through the oval window. Well, that's actually the eardrum, but then going over through the oval window and into the inner ear. But so you've got something blocking your ear here, so the eardrum can't pick up the sound. An obstruction in the outer and or middle ear blocks the transmission of sound. Medical and or surgical treatment may reduce or eliminate this type of hearing loss. So impaired sound transmission through the outer or middle ear. Middle ear is where those little, the anvil, the hammer, and the stirrup are. Often mechanical or inflammatory. Frequently reversible or improvable. So that's like, like you were on an airplane or something like that, and you can't hear for weeks properly, or your hearing's really diminished until that straightens out. Or maybe you've had a really bad cold or virus or something like that. Conductive hearing loss occurs when sound is blocked, reduced, or distorted before it reaches the inner ear. In other words, the sound signal doesn't get delivered efficiently, even though the inner ear and the auditory nerve might be perfectly fine. The things that we were talking about in sensorineural hearing loss, the cochlea and the auditory nerve, they could be just fine, but you can't because there's something sooner than it gets there that's in the way. Unlike sensorineural hearing loss, the inner ear, this type of hearing loss involves problems in the outer ear or the middle ear. So again, how hearing normally works, sound waves enter the ear canal, vibrations strike the eardrum, the middle ear bones, again, this is like the game Mousetrap. The middle ear bones amplify the vibration and sound reaches the cochlea. In conductive hearing loss, steps 1 and 3 are impaired. Steps 1 through 3 are impaired. So outer ear causes of conductive hearing loss, anything that physically interferes with sound entry or transmission. Earwax, you've got the earwax buildup in here. Foreign bodies, got something stuck in here that shouldn't have gone into your ear. Like don't put things up your nose or in your ears. That's something you don't want to do. Ever. Well, yeah, you just don't. I used to, when I had my medical transcription practice way back, this was years ago. So my daughter's 37. So when she was, young, I was a stay-at-home mom. And so I studied medical transcription and I started a transcription business. It was really fun. And um, it really, oh, thank you, Lisa. Thank you. So sorry to hear about Dale, keeping him in our thoughts and prayers, sending you much love. Thanks. And everybody's been so wonderful reaching out to me about this. So thank you so much. But anyway, the oh gosh, now I forgot what I was talking about. Oh, yeah. So anyway, one of the accounts I had was a ear, nose, and throat doctor, and he was really cool because he was very natural remedy minded as well. But he was a great surgeon. But anyway, like he told people no Q-tips, no Q-tips. He says you want to clean your ear, you let the hot water in the shower just run in and out of it, kind of thing. And I know some people have earwax problems that are like you've got to use, you know, Debrox or something like that. But anyway, just generally don't be sticking things in your ears. Um, Foreign body swelling of or narrowing of the ear canal, external ear infections, structural abnormalities, simple mechanical problems. Then you've got middle ear causes, problems that interfere with vibration and amplification. Fluid behind the eardrum, common with colds, allergies, sinus issues. So I know that that's a common thing that people will be like, oh, or eustachian tube dysfunction, and you've been on an airplane, that kind of thing. Middle ear infections, otitis media, perforated eardrum, stiffening or damage to the ossicles, pressure imbalance. They're extremely common, especially in children, people with chronic sinus or allergy issues, or individuals prone to inflammation. What does that feel like to the person? Conductive hearing loss is usually about volume, not clarity, whereas sensorineural hearing loss from the inner ear issues is more about clarity, not volume. Everything sounds muffled or dull. It feels like my ear is plugged. I hear better when people speak loudly. My own voice sounds louder in my head. Sensation of pressure or fullness. So, and you might have this if it's due to something in your ear or whatever, or even if it's a cold or a virus or something like that behind it or a sinus problem, it might not be bilateral, right? It could just be one side. Definitely if it's a foreign object or a wax problem, but you could, with a sinus problem, end up with both ears. But you're more likely probably to have one ear affected, I would think. Pattern and progression. Um, Typical course, often sudden or fluctuating, may change with position, swallowing, yawning, changes in pressure or congestion. Frequently temporary or reversible, chronic conductive loss can occur with repeated infections, like somebody who's constantly, a child who has repeated scarring from repeated ear infections or something like that. Or long-standing inflammation. Structural changes may accumulate over time. So damage to the ear and then scar tissue and blah, 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 blah. Things compound. Still often more modifiable than sensorineural hearing loss. Yes, very often. We just said that. So what you want to do is just find out what's causing it and then go after that. Typically done about it, removal of earwax or obstructions, treating infections or inflammation, addressing eustachian tube dysfunction, pressure equalization strategies, surgical repair in select cases. Those approaches aim to restore sound transmission, not compensate for lost sensory cells. They're just helping to get the freeway open there so the sound can get where it needs to go, into that inner ear where it transmits to the brain. Supportive and integrative considerations, reducing chronic inflammation, supporting sinus and upper airway health, improving pressure regulation, addressing allergic triggers, supporting tissue healing and circulation. The goal is often restoration of normal mechanics, not adaptation to the loss. You have to adapt to a sensorineural hearing loss that cannot be reversed. But hopefully you don't have to do that with a conductive hearing loss. And I just said that. So mixed hearing loss is interesting. So you can have, right? I mean, that makes sense. You could have a little bit of both. So if you could definitely have like sensory neural hearing loss already and then end up with some conductive hearing loss on top of it. Oh, fun. Um, so yeah. So I would say like if you have like if you know you have sensory neural hearing loss and you it all of a sudden gets worse, you could have like a conductive hearing loss on top of it that can be treated. So have that checked out. So a brief detour, I was saying like I forgot last time when I was doing all of the anatomy and the structure and everything, I didn't talk about earwax at all. So I completely forgot about this. Earwax, medically called cerumen, is a natural substance produced by glands in the outer ear. It's a mixture of fatty secretions, sweat-like secretions. It's not because your ears sweat. It's not because you're particularly sweaty in your ears. It's sweat-like secretions. Shed skin cells. So we're constantly shedding skin and making new cells. Despite its bad reputation, earwax is normal, protective, and necessary. What earwax does, this is its job. It serves several important functions. It protects the ear canal from dust, debris, and insects. Yeah. Oh gosh, I have a client who had a large bug fly right into her ear, and she went through, I can't tell you the whole story because I don't remember it all, but it was terrible. I mean, it went on and on and on and on and on forever. And I think she still has hearing loss from it, but it was a bizarre, one of those bizarre things that she was in the wrong place at the wrong time. And this thing just right in there. Um, Traps particles before they reach the eardrum. So, right, the wax sits right here, and there's your eardrum. So it's protecting your eardrum from things hitting it. Provides antimicrobial protection. This is why like the ear is like so far into the face. Like all of this is like behind your sinus. It's like under your eye. Your eye is like right here. And all this part of the ear is there. I just always think it's over here, but it's not. This is over here. um, Provides antimicrobial protection against bacteria and fungi. Moisturizes the ear canal, preventing dryness and irritation. In healthy ears, earwax naturally migrates outward and falls away on its own. That's why Dr. Jorgensen would tell people to let the water just run in and flush it out, right? Because it's going to move towards the front and your shower water will just hit it and like gently remove it naturally. Oh, I've got to I will during the one about natural stuff, I'll do the ear wicking stuff. I'll look at the candling that people do. I'm not crazy about that, but it's one of those really natural things that people do to get earwax out. And I know some people are very skilled at it, so don't let my initial I'm not crazy about it like sway you. I'll have to look into it more and see how I really feel about it. It might end up being like the microwave where I think it's fine now. Um, but um, anyway, don't be shoving it. And you can put a Q-tip in there and just pack it down, right? So, yeah. I mean, I'll use a Q-tip like you get out of the shower and your ear is wet, but just around the very um, entrance there. And I'll stick it down in there. Yeah. Okay. All right. So mixed hearing loss is a combination of both. So you got problems in this area and that area. High frequency hearing loss is next on our agenda. High frequency is the common early pattern. It's usually high frequency that is affected most as you're getting into sensorineural hearing loss. Impacts speech clarity more than volume. High frequency hearing loss refers to reduced ability to hear higher pitched sounds, typically in the range that includes consonant in the range that includes consonants S, F, T, K, sh, and ch. Women's and children's voices, environmental detail sounds like birds, beeps, rustling. Crucially, lower frequency hearing may remain relatively intact, which is why people often say, I can hear you, I just can't understand you. Where it occurs anatomically, I mean. Oh gosh. High frequency hearing loss is almost always a sensorineural tissue issue involving the cochlea. The cochlea is tonotopically organized. High frequency sounds are detected at the base of the cochlea. These hair cells are the most fragile, the most metabolically active, and the most vulnerable to damage. This is why high frequencies are usually affected first. How high frequency hearing loss happens: aging, gradual, cumulative hair cell wear. Begins subtly, often decades before it's noticed. Nearly universal with age. So nearly everybody's going to have some degree of this as they get older. But the rate varies widely. Noise exposure, chronic exposure, music, machinery, earbuds. You can use earbuds. You can listen to music, right? But keep your volume in a healthy place. And then when you're using loud equipment, machinery, ear protection, almost all the time now when you see people out mowing the lawn or working with loud equipment, you always see ear protection on, but that wasn't the way it used to be years ago. And people didn't really realize that it was having that effect. Noise exposure, chronic, okay. Sudden acoustic trauma, gunfire could be an issue. So when you're out there practicing on the shooting range, right, you want to have your ear protection on. Often bilateral, but maybe asymmetric. Importantly, you don't need ear-splitting noise. Moderate noise over time is enough. So yeah, you don't have to have that loud bang. You can just be too loud over time accumulates. And then inflammation, vascular or metabolic stress, reduced blood flow or oxygen delivery, chronic inflammation, mitochondrial. Oh, there we go, mitochondria. So you can be sure mitochondrial energy is going to be part of the preventive route when we get to there. Mitochondrial stress in the hair cells, viral injury. This is where high frequency loss overlaps with COVID-related hearing changes, not just COVID, but other viral kinds of things. Autoimmune processes, circulatory compromise, ototoxic exposure, certain medications, environmental toxins, effects may be subtle at first. Again, very, very similar to the whole list of stuff for sensorineural hearing loss, and high frequency hearing loss is usually the first part of sensorineural hearing loss. What it feels like to the person. People sound like they're mumbling. I hear vowels but miss consonants. I can hear you better when I see your face. Background noise makes everything worse. Women's voices are harder to hear than men's. This explains why volume doesn't fix the problem. Repeating louder doesn't help much. Clarity, not loudness, is the issue. So if you're speaking with somebody with this problem, I would say enunciation is more important than volume. So it's interesting because my father, who had a pharmacy when he was alive, one of his pharmacists, Robin, she would, every older person she would talk to like this. Hi, Mrs. So-and-so. And we were like, one day we were saying, like, Robin, like, just because she's old doesn't mean she's deaf. But that's what we sometimes think. And I think volume does matter. But I think, to a certain extent, but if we can be more conscious that if we enunciate, maybe speak a little more slowly and clearly would probably be more helpful. Why speech understanding is so affected. High frequency sounds carry speech detail, not volume. Vowels use low frequency. They're loud to a person with this hearing disorder and easy to hear. Consonants require high frequency. They're quiet and critical for meaning. So cat, cap, and can may all sound the same. Sentences lose precision. Listening becomes mentally exhausting. Can often lead to social withdrawal, listening fatigue, irritability, and cognitive overload because you're working so hard to do what is supposed to just be happening without you thinking about it. Pattern and progression begins subtly, often unnoticed for years, worsens gradually, may be symmetrical or asymmetrical. High frequency loss may plateau for long periods, progress in steps, worsen faster with continued noise or inflammation. It's often the gateway to broader, more established sensorineural hearing loss. Is it reversible? Damage to cochlear hair cells is permanent. Early functional stress may be modifiable. Once hair cells are destroyed, they do not regenerate. So the goal becomes preserving remaining hair cells and optimizing brain adaptation. Why high frequency hearing loss can go missing. Standard hearing tests may appear mostly normal. People compensate visually and cognitively. Symptoms are blamed on attention, memory, aging, people not speaking clearly. This makes proper diagnosis incredibly important. Yeah, you might get like categorized this way, and it's not. So get your hearing tested by somebody who's an auditory specialist, can really nail that down for you. How it's typically addressed, conventional approaches, hearing aids designed to amplify high frequencies selectively, improve speech clarity rather than volume. Early intervention is key. Waiting makes adaptation harder for your brain. So now we go on to sudden hearing loss, sudden sensorineural hearing loss. Rapid decline in hearing occurs over hours to a few days, most often affects one ear, involves the inner ear, the cochlea, or the auditory nerve. So key features, abrupt onset, noticeable change in hearing, often accompanied by tinnitus, ear fullness or pressure, possible dizziness or imbalance, not caused by earwax, middle ear fluid, or mechanical blockage like in conductive hearing loss. Anatomical location of the injury is the cochlear hair cells, the auditory cochlear nerve, or microvascular supply to the inner ear. Common mechanisms, viral infection, post-viral inflammatory response, microvascular compromise, which can be part of this whole thing, the first two, autoimmune inner ear disease, metabolic or oxidative stress, or unknown cause, things that we don't know why. The pathophysiology, inflammatory cascade affecting the cochlear structures, reduced blood flow to metabolically active hair cells, direct or indirect injury to sensory cells, damage to neural signal transmission through the cranial nerve 8. Recovery is more likely if the primary injury is inflammatory. Hair cells are stressed but structurally intact. Blood flow is restored quickly if that's what the problem is. Permanent loss more likely if the hair cells are destroyed, if neural structures are damaged. Ischemic injury results in cell death. Human cochlear hair cells do not regenerate. I've said that like a million times. Now, this is the thing that happened with my client. So I had a client who I started seeing a few months ago, not primarily for this problem. Come on, I hate it when it does that. But for just as part of her regular intake and everything, that this was what had happened to her, is that she had lost hearing significant, like practically entirely in her right ear following an episode of having COVID. So you can see here sudden hearing loss waves, the effect of COVID-19 infection and vaccination on the inner ear. This didn't have to do with a vaccination. It actually had to do with the infection for her. Sudden sensorineural hearing loss has emerged as a potential complication of COVID-19 infection and vaccination. Various mechanisms by which the SARS-CoV-2 virus can cause hearing loss have been reported, including direct viral invasion, neuroinflammation, blood flow disturbances, and immune-mediated response. However, the temporal relationship between COVID-19 infection and sudden blah, blah, blah hearing loss remains unclear, with mixed findings and conflicting reports, blah, 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 blah. But my client actually had with the testing she had, was able to kind of hone in on the damage that was done to her ear. So that's kind of cool. But you can, if you're interested in seeing that paper, and later when you pick up the PDF, you'll be able to go there and see that. And then there's another page here. There's probably a lot more out there, but I just found a couple of places: COVID-19 and hearing loss, a narrative review. So it goes through a lot of stuff there. So, if you or somebody you know and you're interested, again, you'll be able to click on those when you have the PDF. So a 70-year-old woman in otherwise good health presents with, and I chose this picture. That's not her, but I chose it because she's similar in her physique. She's got long hair like that, and that's about her build kind of thing. So I just wanted to have it be, like, okay. So, and her first name is Susan. Previously normal baseline hearing, history of COVID-19 infection during which this occurred, subsequent high-frequency hearing loss, sound-induced pain, distorted sound perception, poor or no benefit from hearing aids, documented cochlear injury, hair frequency hair cell loss, which has been confirmed, sound-evoked pain, sensory gain dysregulation. So the pattern is consistent with sudden sensorineural hearing loss, not conductive pathology. So from my notes, I had written this down. Susan had inner ear disruption from COVID to the point of losing about 50% hearing in July of 22. Audiology studies have shown inner ear damage irreparable. Hearing aids don't work. The high range is the worst, the most affected. Pain associated with high-pitched sounds. Pain. Actual literal pain. Not loud sounds, with high-pitched sounds. Which is why the hearing aids don't work. It's not a hearing thing. She thinks since doing the 7-day course of nicotine patches, she might sense that there has been an occasional auditory sound, almost like tinnitus. Oh, great. I'm like, wonderful. That wasn't present before, that comes and goes and not that frequent. So what I want to say about that is when she said she had this hearing loss, blah, 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 from this time, and it was COVID related, I recommended she try the 7 milligrams of nicotine transdermal for 7 days because of the study that confirmed in 100% of the cases that long COVID symptoms, not including hearing, but all of the other stuff, responded. So why not try? So she did end up, something changed. She ended up with an occasional auditory sound that she gets that she wasn't getting before. It's almost like tinnitus. And I'm like, great, did we cause a problem? Well, no, we didn't cause a problem, but it shows, okay, so let's kind of try to analyze this. So the anatomical pattern, high frequency loss, the basal turn of cochlea, most affected, no middle ear involvement, no mechanical obstruction. Signature pattern of inner ear cochlear injury. Proposed mechanisms of injury. How might SARS-CoV-2, the COVID-19 virus, cause sudden deafness? Microvascular injury or hypoperfusion. So we know that clotting is a big problem with COVID and with COVID-19 vaccines. So the cochlea has an end artery blood supply, the labyrinthine artery. There's no redundant circulation. In other words, if you get something obstructing there ischemically, there's not like another vessel to come in and compensate. Extremely high metabolic demand, very low tolerance for ischemia, okay, for like a clot issue. COVID is associated with endothelial inflammation, so inflammation of the blood vessels. Microthrombi formation, clotting formation, impaired nitric oxide signaling, and nitric oxide dilates our blood vessels. Capillary flow dysregulation. So these things happening, I talked about the ocular problems that I had with COVID. Um, Result, reduced oxygen delivery, hair cell death, permanent high frequency loss. Represents capillary level ischemia, not large vessel stroke. Could be inflammatory cytokine toxicity. So you end up with this inflammatory cascade of cytokines, interleukin-6, TNF-alpha, interleukin-1 beta, interferons. These cytokines cross the blood labyrinth barrier, disrupt glutamate regulation, increase oxidative stress, trigger apoptosis or program cell death in the cochlear hair cells. Consequence, outer hair cell loss, sound distortion, sound-induced pain, which my client Susan has, hyperacusis like physiology, and hair cells do not regenerate. How many times can we say that? That sad fact. And then there's the stria vascularis dysfunction right here. Maintains the endocochlear potential, regulates potassium signaling, cycling, is highly metabolically active, is sensitive to a lack of oxygen and inflammation. Damage results in high frequency hearing loss, distorted sound processing, reduced benefit from amplification, persistent auditory dysfunction. And structural damage in this region is typically irreversible. COVID-19 associated neuroinflammation may involve cranial nerve. 8, myelin integrity, central auditory pathways, clinical implications, amplification increases discomfort, distorted sound perception, poor speech discrimination, central auditory gain changes. It was really interesting too when she was sitting here in the office, my phone rang to the left of her ear and she thought it was on the right. And we found that fascinating. Like it also disrupts like where you sense the sound is actually coming from. So integration of mechanisms, inflammation and blood flow disruption are interdependent. Combined effect, you have microvascular ischemia plus inflammation and neural sensitization. Why this case is structurally irreversible. The basal cochlear hairs have been cells are destroyed. The stria vascularis compromised and neural signaling altered. Permanent audiologic changes. This is not conductive hearing loss. It's not mechanical obstruction. It's not simple labyrinthitis. Structural inner ear injury. Secondary central effects. Brain increases central auditory gain. Sensory gating may change, internal sounds may emerge, like she just had. Perception becomes amplified or distorted. Central adaptation does not restore hair cells, but influences symptom expression. So micro those things. Anyway, back to Susan. So baseline status, again, I said all of that. Interpretation was the basal cochlear damage, structural, not mechanical loss. That was all established. So we just tried the nicotine trial. 7 milligrams of transdermal nicotine for 7 days. Put a new patch on every day. Trial based on emerging long haul COVID discussions. No immediate adverse effects reported or later. The client reported occasional internal auditory perception described as almost like tinnitus, not constant, comes and goes, not frequent, not previously present. Clinical interpretation of the new sound. So what I'm thinking is, okay, the pattern is intermittent, transient, not progressive, not worsening baseline hearing. It is not consistent with new structural cochlear damage. More consistent with transient auditory pathway activation, central gain modulation, cholinergic influence on neural signaling. So this is what I'm thinking. And the nicotine affects the auditory nerve, the cholinergic. So she may have had some stimulation. Does nothing to do with the cochlear hairs, but that new sound was not damaged. It's not like the nicotine caused tinnitus or anything like that. It's that it may be giving some oomph to the nerve. And so she wanted to do another course to see if that will change anything for the better, if she gets any better kind of thing. It's all hypothetical and it's not anything based on anything but that it won't harm you. And you did notice some change. So nicotine does not regenerate hair cells. Any perceptual shift reflects central processing change, not cochlear repair, nor does the new sound present as any sign of damage. So let's wrap this up. Today we've examined the major forms of hearing loss, how they differ, where they originate, and why understanding the mechanism matters. We've seen that aging and long-term noise exposure quietly place our hearing at risk. That's so funny. Long-term noise exposure quietly. That's interesting the way I worded that, but in the background. Place our hearing at risk, and that hearing loss can also appear suddenly, whether seemingly out of nowhere or following an acute event, such as in Susan's case after COVID-19 infection. Next time, as I said, we'll move into auditory dysfunction such as tinnitus and other sound perception changes, and then into vestibular distortions, including vertigo and Ménière's disease. In the session that follows, we'll focus on what we can do proactively to protect and support our ears so that we can preserve clear hearing for as long as possible. One last thing I did want to say, because I said I would mention it. So this is an example of an acute illness that results in a life-changing long-term problem. It reminds me of Satum, my client who was actually on my radio program years ago, so she doesn't mind if I use her name, but she ended up with dermatomyositis after a flu shot. She suffered acutely and then had to be on disability, full disability, because she ended up with an autoimmune disease from that vaccine. And then my husband, Dale, who had norovirus, who had the stomach flu December 10th, and as a complication of that acute illness, developed an inflammation, a paralytic ileus in the colon that now has failed all efforts to correct and is hopefully going to be able to be corrected surgically. So you take something that's an acute illness and wham, it changes your life. That can happen. So anyway, our bodies are really something else, and let's treat them as well as we can. With my husband's thing, there's absolutely nothing I can do about that. I can really help him when he comes through to build back, to make sure he doesn't develop adhesions in the colon from the surgery, and I can help with a lot of things to build him back, but there's nothing I can do about that obstruction. And so that's where your modern medicine really shines and keeps you alive. So that's really wonderful. So I hope you all have a wonderful Valentine's Day, a great weekend. Hopefully I'll be back next weekend. I'll always be it'll kind of always be a last call, probably depending on where things stand with Dale's progression. But hopefully it'll be next week. Thanks for being with me, and I will send out an alert when the video is up on YouTube for you to access, to share, or see again, and also the PDF here of this PDF that I just went through. So let me just see, stop my share to say all that. And I hope you're so welcome, Lisa. And thanks everybody for being here. And take care. Be well.